مثل ما تعرفون we have 5 types of leukocytes, the neutrophils, lymphocytes, monocytes, eosinophils and basophils. This is the blood film picture of the blood. Contains the white BC, the bioconcave shape of the erythrocyte. We have the lymphocyte with dense hyperchromatic nucleus, which occupies about 80 to 85% of the site of the cell size, with a thin rim surrounding its nucleus. We have the monocyte with a bean-shaped nucleus. The monocytes in the blood will be converted into macrophage when enters the tissue. We have the granulocyte. It's named so because they have granules in their cytoplasm, and according to the staining they take, these granulocytes are divided into 3 types. First, the neutrophil with the 2 to 3 segments of the nucleus and have neutral colored cytoplasmic granules. We have the eosinophilic with the biolobed nucleus and eosinophilic staining granules, and the basophil, which takes the blue colored blue coloring of the cytoplasmic granules. So these are the granulocytes. We have 3 types: neutrophil, eosinophils and basophils. We have the monocyte and we have the lymphocyte. Of course, we have the platelets which are part of the megakaryocytes in the bone marrow. The erythrocyte, its precursor in the bone marrow is the erythroblast, and the precursors of the white BC according to their type. White BC synthesis of course comes from or occurs in the bone marrow by the process of leukopoiesis. So the leukopoiesis is defined as the process of production or synthesis of the white blood cells or the leukocytes in the bone marrow. Total leukocyte count is about 4,000 to 11,000. This is 9 for the x is 10 for the x is 9 per liter. يعني عادة احنا بالكمبليت بلاد بيكتشر هو عدد حوالي 4000 الى 11000 بالديسيليتر الواحد، او 4 الى 11 في 10 مضروب للقوة 4 القوة 9. الهاف لايف اوف ذا وايت بي سي قد عادة هو يوم واحد، تتراوح من عدة ساعات الى او قد تتراوح من ساعات الى ايام. الرينج مال تقريبا 1 داي. بينما الوايت بي سي الريد بلاد سيلز هو حوالي 120 يوم. يعني عمر الار بي سي يكون كلش طويل مقارنة بالوايت بي سي. الجرانيولوسايتس we have neutrophil, eosinophil and basophil. mononuclear cells تشمل المونوسايت and the lymphocyte. White BC count, normal differential count in the complete picture in the adult is like this. Neutrophil it's about 40 to 80% of the cells of the white B cells. طبعا lymphocyte الشكل لنا 20 إلى 40%. المونوسايت 2 to 10%. eosinophils 1 to 5, and the least white BC percent is the basophil, which about 0 to 1%. So we have the most common type of the white BC is the neutrophil, and the least type is the basophil. Normal absolute white BC count is like this. Neutrophil is about 2 to 1,000 cell per deciliter. Lymphocyte 1 to 4,000 per deciliter. Monocyte 1,000. eosinophil 500 cells per deciliter. Basophil about 100 cell per deciliter. How we can calculate the count of the cells? As we know, we have if we have a complete blood picture with total white BC count about 6,000 cell per deciliter, and the ratio where neutrophil 60%, lymphocyte 34%. We want to calculate the number of the neutrophil. Will be we multiply the 6 by 60%. There will be 3,600 cell per deciliter, or 3.6 multiplied by 10 for the x is 9 per liter. While the lymphocyte we can calculate easily by multiply the 34 by 6. It will result in 2.04 per or 2040 cell per deciliter, or 2.04 per multiplied by 10 for the x is 9 in 1 liter. Neutrophil, the function of the neutrophil is like this: it's engulfing the bacteria and other organisms in acute infection. So the most predominant cells, as you know, in the acute inflammation is the neutrophil, and it participates in killing the foreign organisms and bacteria by phagocytosis. The eosinophil mediate the allergy and parasitic infestation, and we have its role in the type 1 hypersensitivity with the IgE stimulation for the eosinophil. Basophil, of course, also participates in the allergy, and it also participates in the type 1 hypersensitivity. Lymphocyte, we have two types, as you know, B and T lymphocytes. Their role in the immunity and defense mechanism against especially cancer and viral infection, but also it participates in any function of cell-mediated immunity. Monocyte engulf the bacteria, especially in the chronic infection and inflammation. It converts to macrophage in the tissue. ولهذا وظيفة النيوتروفيل أهم شيء هو بالأكيوت انفكشن، لأنه تساهم بالتهام البكتيريا بعملية الفاكوسايتوسيس. الإيوزينوفيل تساهم بعملية الألرجي. كذلك البيزوفيل. الليمفوسايت عندنا T and B lymphocyte role in the immunity and defense mechanism against cancer and the viral infection. ولهذا الفيرال انفكشن عادة ما تدخل وياه النيوتروفيل وإنما تدخل الليمفوسايت. المونوسايت engulf the bacteria، وهي تتحول إلى الماكروفاج عندما تدخل للتشو عند الحاجة. زين، what are the disorders of the white PC of the leukocytes? It's either benign like abnormal white PC count or abnormal white PC function, or infectious mononucleosis syndrome due to Epstein-Barr virus, or malignant white PC disorder like in acute leukemia, chronic leukemias, myeloma, and lymphoma. So we have non-malignant or non-tumorous white PC disorders, which are there is a difference in the white PC count or abnormal white PC function, or the or getting infectious mononucleosis syndrome, while the malignant or the tumorous disorders of the white PC include leukemia, both acute and chronic, lymphoma, and myelomas. Abnormal white PC count, we will discuss the first part of the abnormality of the white PC, which include the non-tumorous disorders of the white PC. First, the abnormal white PC count. As definitions, the terms leukopenia, it refers when white PC is less than 4,000 per deciliter. It's called leukopenia, which means reduced level of white PC below the lower limit, while leukocytosis when white PC is more than 11,000 per deciliter. Neutrophilia, it means a high neutrophilic count, while neutropenia, low neutrophil count. Lymphocytosis, high lymphocyte. Lymphopenia is the converse. Monocytosis when there is high monocytic count. Eosinophilia, high eosinophilic count, and it's seen more in the allergic condition, or some tumorous conditions. Basophilia when there is high basophilic count, and it's more countered in the allergic conditions. Neutrophilia when the neutrophil percentage is more than 80%, or absolute count when it's more than 8,000 per deciliter. Main cause of the neutrophilia, as we see here in this picture of the blood film, there's an increased number of these neutrophils, which are 3 lobes or more, with the neutral colored granules in their cytoplasm, and the absolute number is more than 8,000 cell per deciliter, or its percentage when it's more than 80% of the total white PC. Okay. This is the lymphocytosis when there's increased lymphocyte number, more than 80% of the total white PC, or its count more than 4,000 per deciliter. The main cause is the acute viral infection, while in the neutrophilia, as we said, it occurs in the acute bacterial infection. Eosinophilia is more seen when there's percentage is more than 5% of the total white PC, or the absolute count is more than 0.5 or 500 cells per deciliter. The main cause, the parasitic infection or the allergic conditions. As we see here, these are the eosinophils with the dark red granules and the characteristic two-lobed nucleus. These terms are due to the abnormal levels of the white PC. We will discuss some abnormality of the white PC function. Also, the white PC sometimes they are normal in count, but they have changed function. The function is either inherited, or this abnormal white PC function is either inherited or acquired cause. Patient usually presented with recurrent infections. As we know, the white PC, the main role is in the immunity. So any disorder in the white PC function will lead to recurrent infection. There will be no defense mechanism against the infection. So we see the person, especially from the early childhood, the child has recurrent episodes of different types of infections, especially the respiratory type of infections, bronchitis, pneumonia, tonsillitis. This abnormality of the white PC may be inherited or acquired cause. White PC count here may be normal, but the function is abnormal. Infectious mononucleosis syndrome is a benign disorder characterized by blood lymphocytosis, but not just an increase in the number, but the lymphocytes are even atypical. This syndrome is associated with infections by Epstein-Barr virus and usually associated with positive. How we can diagnose the Epstein-Barr virus? It's an aerosol or an air droplets transmitted infection. Can be diagnosed by doing a test called monospot test for neutrophil antibody. Clinical signs of the infectious mononucleosis include acute pharyngitis, tonsillitis, and gray-white exudate from the tonsil with a lymphadenopathy in the neck. There is an increased number of the big-sized cervical lymph nodes with acute pharyngitis, tonsillitis, and there's a white exudate is coming out from the tonsil. يعني المريض اللي عنده infectious mononucleosis syndrome نتيجة إصابته بالإبشتين بار فيروس راح يعاني من acute pharyngitis، التهاب بالبلعوم والتهاب باللوزتين، ونشوف أكو إفرازات بيضاء تخرج من التونسلز من اللوزتين، مع هناك lymph adenopathy، مع هناك كبر بحجم السيرفايكال lymph node. عادة يعني هاي الحالة تكون عادة باليانج ادلت، عادة تنتهي نهاية سليمة. من المفارقات انه الانفكشيوس مونوكلوز سندروم اذا يعني مثلا طفل او شاب يعاني من تونسيلايتس، وعندما يستخدمون الانتيبايوتيك خاصة من نوع الاموكسيسيلين، ردة فعل الفيروس انه يظهر بشكل اكو ريد راش، اكو عبارة عن طفح احمر يظهر على الجلد، فالشخص يعني يتصور انه هي حساسية من دواء البنسلين، ولكن هي بصراحة ردة فعل الفيروس ضد دواء البنسلين نتيجة افراز توكسينز فروم ذا فيروس، فيظهر بشكل طفح احمر. هو بالحقيقة هو مو سببه allergy to the drug, but it's a response of the virus against the antibiotic. Microscopically or histologically, the tonsil affected by Epstein-Barr virus will have reactive lymphoid hyperplasia with extensive immunoblastic proliferation in sheaths and nodules. We have large lymphocyte which called immunoblast running in sheaths and nodules، مترتبة بشكل sheaths and nodules. This is grossly or macroscopically or by naked eye vision. We have see a large tonsil with a white exudate is going out from the tonsils. These are the blood film. We see atypical lymphocytes in the blood film، بالإضافة إلى أكو زيادة بعدد الليمفوسايت cells in the blood film، ولكن أيضا هناك atypical cells. Differential count for the infectious mononucleosis. Other viruses can or other conditions can produce similar clinical signs and symptoms, include cytomegalovirus, HIV, human immunodeficiency virus, human herpes virus 6, hepatitis virus. Toxoplasma gondii also may produce such effect with fever, lethargy, night sweating, sometimes atypical lymphocyte in the peripheral blood, these are differential diagnoses can be done by doing monospot antibody against neutrophil antibodies. Complications of the infectious mononucleosis may include neurological complications. They are rare but may include encephalitis اللي هو معنى التهاب الدماغ أو seizures اللي هو نوبات الصرع. hematological complications تشمل granulocytopenia، يعني كل الخلايا اللي هي الجرانيولوسايتس اللي هي النيوتروفيل والبيزوفيل والايوزوفيلز راح تقل. ثرومبوسايتوبينيا احيانا تقلب بالبليتلت، حتى احيانا توصل الى مرحله تكسير الار بي سي، وبالتالي راح تنتج الهيموليتيك انيميا. قد يسبب لنا سبلينيك رابتشر، انفجار بالطحال، ريسبيراتوري كومبليكيشنز كانه تشبه النيومونيا او النيومونايتس، هيباتيك كومبليكيشنز يسوين احيانا هيباتايتس هذا الابشتنبار فيروس. والموست dangerous type of complications is the development of lymphoma. So we finished the disorder or benign disorders of the white BC, which included differences in the number and count, differences in the function of the white BC or abnormality of the function of the white BC, and the infectious mononucleosis sign. We will talk a few words about the tumors of the white BC, which include leukemias, lymphoma, and multiple myeloma. Leukemias is the malignancy of the white BC. Classification can be acute and defined as acute lymphoid leukemia, which is leukemias of or malignancy of lymphoid lineage, while acute myeloid leukemia, the other types of the cells. Also, there's a chronic type of leukemia, also classified as chronic lymphoid leukemia and chronic myeloid leukemia. Acute leukemias, there's acute is malignancy of the white BC characterized by abnormal proliferation of malignant cells, which are the blast cells, which are the precursors, present in the bone marrow. It means immature cells. We see such immature cells or blast cells in the peripheral blood and in the bone marrow. As we know, the bone marrow has stem cells. These stem cells can differentiate into different types of cells, which include white BC, platelet, or red blood cells according to the need of the body. But in the leukemias, no, the stem cells will be directed to develop just one type of the cells, which are the blast cells, with no proliferation or maturation towards mature cells. This is a picture of acute leukemia characterized by defect in the stem cells or progenitor cells with the release of immature cells in the peripheral blood. These are immature blast cells, immature cells liberated from the bone marrow into the peripheral blood. Also, the bone marrow also contains such abnormal malignant cells. Etiology of the acute leukemia, of course, there are no exact etiologies or causes for the development of the acute leukemia, but as we know, ionizing radiation, oncogenic viruses like Epstein-Barr virus or human herpes virus 6 or human T-cell leukemia virus. Genetic factors also may have effect on the development of the leukemias, and the chemicals like plating lesions or other some strong chemicals may have an etiology, maybe an etiology for the acute leukemia. What are the clinical features of the acute leukemia? The patient with acute leukemia will have anemia due to marrow infiltration by blood cells. There will be no protection of the red blood cells, bleeding due to the thrombocytopenia. Also, the infiltration of the bone marrow by blood cells will cease or stopping the production of the megakaryocyte and the platelets, so there will be thrombocytopenia. Infections, even when there's an increased number of the white BC, but these white BC are disordered with limited functions against the infectious agent. There will be lymphadenopathy due to the infiltration of the lymph nodes by the malignant cells, and also the same reason with splenomegaly and hepatomegaly. توسع بالطحال وزيادة حجم الكبد. What are the investigations done for the acute leukemia? Of course, we will do complete blood picture and blood film. Usually, we will see anemia. There will be reduced number of thrombocytopenia. The white BC instead of the upper limit is 11,000, it will reach about 200 to 300,000 cell per deciliter. But maybe also normal number or decrease, but there is abnormal function on morphology of these cells. So in addition to the increased number, there will be abnormality of the function and abnormality of the morphology. Bone marrow examination, BM, it means bone marrow examination showing extensive infiltration by a blast cell. Other investigations done for the leukemias include cytochemistry. We stain the blast cells with a chemical stain, cytogenetic, which means chromosomal analysis, molecular analysis for genetic study, immunophenotyping, studying the antigens on the malignant cells, and sometimes we use electron microscope. Treatment of the acute leukemia, because they are rapidly dividing cells, so there will be response or dramatic response for the chemotherapy, and there are many extensive success in the treatment of the acute leukemias, especially in the children. What about the chronic leukemia? That means the chronic malignant disorder of the white PC characterized by abnormal genetic defect at the stem cells or progenitor cells. We have two types: chronic lymphoid leukemia and chronic myeloid leukemia. Also the same thing about the development from the stem cells. There will be no proliferation and maturations toward the mature white PC. Instead of that, there will be proliferation of blast cells, which are malignant mature cells. These disorders develop insidiously with chronic onset, while in the acute there will be rapid onset. In a chronic, the events run step by step and takes more time to develop clinical signs and symptoms. The above picture is about chronic myeloid leukemia. There are abnormal myeloid progenitor cells in the peripheral blood, immature cells, large cells with ugly phenotype. In the chronic lymphoid leukemia, there will be development of an increased number of the lymphocyte, of course with abnormal function and morphology. In addition to that, there's also a tumor called multiple myeloma. It's a white PC malignant disorder characterized by abnormal proliferation of a malignant plasma cells. This is a definite tumor for the plasma cells. As you know, the plasma cell, they are B cells that transform to plasma cells for protection of antibody. So multiple myeloma, it's a malignant tumor of plasma cells. So there will be an increase or synthesis of abnormal amount of immunoglobulin called M protein or paraprotein. Usually these patients with multiple myeloma have bone lytic lesion, which means decreased density of the bone and easily fractured. As we see here in the vertebra, in the skull, there is what we call hairy-like appearance and decreased bone density of the skull. Instead of maturation towards the white BC and white B cells lymphocyte, there will be production of abnormal plasma cells, which are the malignant type of plasma cells, which called multiple myeloma. What are the investigations for multiple myeloma? Complete blood picture and blood film. ESR is usually increased. Bone marrow show infiltration by plasma cells, and by doing protein electrophoresis for serum and urine, we will see a spike for the M protein. Urine M protein called here when this M protein is discarded in the urine, we can detect it, and here in the urine it's called Benz-Jones protein. Calcium, of course, is increased because there's lysis of the bone, destruction of the bone with liberating of the calcium toward the peripheral blood. So there will be ESR increased, M protein production, Benz-Jones protein, which is an M protein in the urine called Benz-Jones protein, and serum calcium is increased. These are plasma cells. As we know, the plasma cells have eccentric nucleus toward the periphery. These are, of course, abnormal types of plasma cells, malignant type of plasma cells. In general, what are the oral manifestations of leukemias? 65% of patients with leukemia will review an oral signs and symptoms, include gingival bleeding, petechiae, and ecchymosis. We should make a differential diagnosis for this gingival bleeding, which include thrombocytopenia, hemorrhagic diathesis or coagulation disorders, anticoagulant drugs, liver cirrhosis, and end-stage renal disease, who have dialysis treatment. All these disorders have also oral bleeding and gingival bleeding, so we should differentiate it from the leukemia by doing blood film and complete blood picture. This is very clear gingival bleeding, chronic gingival bleeding, so we should differentiate the cause, and we should know all the causes that may cause gingival bleeding to differentiate it from the leukemias. Gingival enlargement, there will be gingival hyperplasia, usually caused by local inflammatory conditions due to poor oral hygiene, food impaction, or mouth breathing. Systemic conditions such as hormonal changes, drug therapy, or tumor infiltrates also may produce or increase the severity of the gingival hypertrophy. As we see here, there will be hyperplasia of the gingiva, which may lead to loss of teeth. Gingival ulceration and oral infections, of course, due to the decreased capability of white PC for defense mechanism against the infection, so there will be recurrent oral infections and gingival ulceration. We should differentiate it from the Candida albicans and herpes simplex infection virus. Oral ulceration and infections also may be clinical signs or oral manifestations of leukemia, both of acute and chronic type. Okay, thank you very much. This was a short lecture about the abnormality of the white PC.